Thank you very much, Ambrose, for the introduction. Thank you very much for the invitation to come again to the beautiful Biarritz. I'm very happy to be here, and I'm hoping to present you some unpublished data on new activities in the field of the treatment of chronic treatment-resistant heroin-dependent patients. So, in the late 1990s, Ambrose Uchtenhagen and his group started to treat heroin patients that didn't respond to methadone with heroin, medically prescribed heroin. And so we built on that experience in the Netherlands, and we did some research there. And I will show you that it was quite successful, and that we could treat successfully another 50% of the patients. And still, we're left with another 50% of patients that maybe didn't do so well. So we're still looking for additional options to get into contact and to have better outcomes for these patients. So that's what I want to share with you this 20-25 minutes. So I will say a few words about heroin-assisted treatment for treatment-resistant patients. Then I will show you the problem that we actually encountered. And one of the problems was co-occurring heavy cocaine use, and how we try to address that problem. I will try to speak slow because I think the translators need a little rest right now, isn't it? Okay, so heroin-assisted treatment. As I told you, it was started in, actually I have to say, it was started, of course, in the US, but that was before methadone was around. It was started in Switzerland, when methadone was around, and it turned out that methadone is a great treatment, and it saves many lives. It creates many good lives for many heroin addicts, but it doesn't be effective in all patients. So we started to think that maybe something additional was needed. And so after, in Switzerland, there was a big cohort study, we thought that you have to do randomized controlled trials, because that's at the end the way you can prove efficacy. I had the luck to see the discussion on baclofen here. I think also the ones who really want baclofen for their patients support randomized trials. It makes it much easier to get it available for all people. So we started the randomized trials, and they've been described. This is just one of the publications. This is a big one if you want to know everything about it. This is 150 pages on everything that was done on the heroin trials in the Netherlands. This is, okay. But more important, this was the results of the 2 randomized clinical trials that we did in the Netherlands, and it was published in the BMJ in 2003. And meanwhile, it's being cited about 150 times. So it made an impression. So this was comparing treatment-resistant, treatment-refractory methadone maintenance patients who continued methadone maintenance trace with patients who, in addition, got heroin, pure heroin prescribed by us. This was the type of patients that we met at that time. They were a total of about 600 patients. Mean age was 39. It must say 19% females, not 90% males. They were using heroin for 16 years. And in the last month, they were using heroin in 26 days a month, although they were using methadone on average about 60 to 80 milligrams. They were using cocaine for 10 years, 90% of them. And they were using cocaine on 18 days in the last month. And of course, they were using all kinds of other drugs. And they were not doing very well in terms of physical, mental, and social health. So we decided a priori that we should have a very strict outcome for success in this trial. And so this were the primary outcome of being a responder. It meant that you had at least 40% improvement in mental health and or at least 40% improvement in physical health and or at least 40% improvement in social functioning. At the same time, if you would deteriorate on any of these dimensions, you would not be a responder. And also, if you improved very much on all these dimensions and you were using more cocaine, you can debate whether you're a responder, but we decided that you're not a responder. It doesn't happen so often that you use much more cocaine and doing better and all these things, but we decided you're not a responder. So these were the basic results, just to repeat it quickly. And what you see here is, just also for the translator, you see we had actually 2 randomized trials. In the Netherlands, 90% of our heroin addicts are smoking heroin, and only 10% is injecting. So we decided that we have a separate trial for injectors and a separate trial for smokers. The smokers was important for the Netherlands, the injectors was important for the international community. So here is the results from the injectors, and what you saw is in the methadone maintenance continuation patients, there was about 27% who improved in one of these domains and 5% who improved in the 2 domains. So you see a response rate of 32%. Whereas in the heroin trial arm, it was 57%, a difference of 25%. Here you see the inhalers, the smokers. You see something very similar, 25% responders in the methadone group and 48% responders in the heroin group, which is a difference of 23%. If you translate that to numbers needed to treat, then your numbers needed to treat of 4, which means that you have to treat 4 patients to have 1 responder extra. So this is a big effect size if you think of these treatment-resistant people. So how did these people who respond, how did they look like in terms of physical health? Actually, what we saw that in terms of their physical health, there was a big improvement. Also in terms of their mental states, this is the SCL90 score, there was a big improvement. Again, in terms of illegal activities, the number of illegal activity days went down from 13 to 2. And also in terms of non-contact with non-drug users, it was an improvement. And even, and it's very important to notice that in terms of cocaine use, some people said if you give them the heroin, they will use the money that they've left to use more cocaine. That didn't happen. They started to use less cocaine. Not much less, a little less, but not more. So it was an effective treatment, and we looked whether there are any predictors of effectiveness, and we actually didn't find any. We had something like 32 predictors, and actually there was only 1 predictor that predicted a good outcome, and that was the number of times people went in abstinence-oriented treatment before. We don't know how to explain that. Probably it has something to do with experience with treatment. Actually, if we looked at cocaine use, the level of baseline cocaine use predicted treatment retention, but not treatment outcome. We thought there would be much worse outcomes, but that was actually not the case. It did predict treatment retention. So this is the Cochrane review about heroin-assisted treatment. I'm not going to read it. It's very positive by now. They say it's an effective treatment, but there are side effects, and it is a second-line treatment. It's only for those who are treatment-resistant to the currently available treatments. So it's a very positive, and there is a very nice EMCDDA monograph on it. This is the situation in the Netherlands now. You have to realize that this is a small country. If you drive by car from here to here, it takes you about 2.5 hours. Then you cross the whole country. So we have in this country with 17 million people, we have now 20 treatment units over the countries, heroin-assisted treatment units, and the number of patients being treated, and that is about 1,000, which is about 8 or 9% of the total population of heroin-addicted people in the Netherlands. So it's a small but important part of the treatment population with heroin addiction. This was still a problem for us. We didn't see a great reduction in cocaine dependence. So we started to think, can we actually improve outcome in this group of treatment-resistant methadone maintenance patients that we can treat with heroin on medical prescription? Can we improve that outcome even further? So we started to look what we could do with this situation with the cocaine, because this is what we had. Heroin-assisted treatment is effective. However, very modest reduction in cocaine use. At baseline, 84% cocaine use, 16 days a month, but after 12 months, still almost 80% using cocaine and 11 days per month. It's still quite worrisome, and it is a treatment discontinuation predictor. So we looked for solutions for that. Maybe we can add interventions. So let's look at pharmacotherapy, combining heroin, methadone with another pharmacotherapy. At that time, we didn't see any proven effective pharmacotherapy, so we looked actually in psychosocial interventions. And if you look there, it's actually quite obvious. We looked at the Cochrane trial, the Cochrane review, and we looked at the NICE review by Dutra. And so this is what the Cochrane trial said. Results are in favor of treatments with some form of contingency management in respect to both reducing dropouts and lowering cocaine use. So we thought maybe contingency management is something. And this was the conclusion from the Dutra review. Cognitive behavior theory and relapse prevention evidence low moderate effect sizes. But treatments using contingency management produced moderate high effect size. So again, we thought maybe contingency management is the thing to go for. So it's not responding. Yeah. So we decided maybe that's what we're going to do. Let's look at the efficacy of 6 months ongoing heroin-assisted treatment plus cocaine contingency management directed at reducing cocaine use, versus 6 months of ongoing heroin-assisted treatment alone in chronic treatment refractory heroin-dependent patients with substantial cocaine use. They have to use a substantial amount of cocaine. These were the outcomes. Outcomes should be change in cocaine consumption, maybe further improvements in physical, mental, and social health, and of course, treatment retention. So this was the design. People would come into heroin-assisted treatment. So these were patients who failed in methadone maintenance treatment. They came into heroin-assisted treatment. They had to be in heroin-assisted treatment for 2 months, and then they could be randomized to either heroin-assisted treatment plus 6 months of contingency management, and then they would go back to heroin treatment alone. That would be the experimental group. The other group would start or would continue with their heroin-assisted treatment, and after 6 months, they would go into heroin-assisted treatment plus contingency management. We knew there were also some people who probably didn't use a lot of cocaine and would not be eligible for our trial, and we used them as a naturalistic comparison group. So, what was the target population? As I told you, chronic treatment refractory heroin addicts in heroin-assisted treatment for at least 2 months, clinically relevant cocaine use. And how did we define that? I'm not going into the details. In the month before they started the heroin-assisted treatment, they had at least to have 1 cocaine-positive urine and at least 4 days of self-reported cocaine use. And at the time, the 2 months after heroin-assisted, they still had to be using cocaine regularly. These were the assessments: urinalysis 1 to 3 times per week, rapid test followed by laboratory verification, interviews bi-monthly using the European Addiction Severity Index and all kinds of other measures. Of course, cocaine use, self-report, and a measure of craving. These were the primary outcome measures. I will come to that. Based on urinalysis was the primary outcome, but of course, we're also looking at other measures in terms of total number of cocaine metabolite-free urines, percentage of patients with cocaine metabolite-free urines for at least 8, 12, or 16 consecutive weeks, and we're looking at patterns of craving and treatment retention. And finally, we also wanted to look at our multi-domain outcome criterion. I'm not going to go into detail here. We did supervised collection of urine because, as you know, if there is something at stake, people tend to lie. That's not only true for heroin addicts, that's true for me and you probably. If there's a lot at stake, you lie. So we did supervised collection of urine samples. We did rapid tests, and in cases that was negative, they were reinforced with vouchers. In case they were positive, there was no punishment, but there was no reinforcement. Positive tests were always sent for confirmation because we're not going to punish anybody for a wrong test. So the outcomes were entered in a web-based computer program, and so we could actually have a very well system of rewards, changing rewards, extending rewards, and you can read the details about that, according to the lines that are being used in contingency management. This was our study group, the sample. We started off with 555 patients that were screened, and some of these people didn't start heroin-assisted treatment. So we had 490 that do that. And of these, 12 didn't start their heroin-assisted treatment. People don't believe it. They think if you can get heroin, they will all do it. They don't. Some people don't want to lose their freedom, and they don't get into heroin-assisted treatment. So in this case, there were 12. So we had 478 patients starting heroin-assisted treatment. After the 2 months, we only had 222 who still met criteria for entrance in the cocaine trial, because not all of them used enough cocaine to be eligible for the cocaine contingency management trial. So we had, at the end, 111 in the control condition and 116 in the experimental condition. On the way, we had a problem with the computer program, and data got lost of 13 patients. So at the end, our intention to treat analysis was 107 in the control condition and 107 in the experimental condition. This was the sample characteristics. And what you see, they're again 5 years old, because the study started about 6 years after the original study. You see, we're growing old together. So they were now 55 years. Female patients, again, 15%. Here you see the substance use characteristic, and you see they're very chronic users, but they're using cocaine a lot. 99% were using cocaine, and of course that was the selection, and they used it on 19 days per month. So this is heavy cocaine use. And this is the health stated, and maybe important to know, 87% were inhalers, and only 14% were injectors. So this is beginning of the data, the results. What you see here is the assessment adherence. People handed in their urine samples, and you see there was actually very, very good over the 6 months. Very high levels of compliance with the study. And this is, of course, more important. And you see there's a little small, because I take it immediately out of the report. This is very fresh data. So this is the results. Here you see the control condition, heroin-assisted treatment only, and here you see heroin-assisted treatment with contingency management. So what you see here, the number of weeks, longest duration of cocaine abstinence. So the heroin-assisted group had a mean of the longest duration without cocaine use of 1.8 weeks, whereas that was in the experimental condition, it was almost 4 weeks. It's highly significant, and the effect size is 0.46, which is a moderate large effect size. If you look at the secondary cocaine-related outcome measures, what you see here is the number of cocaine-negative urines. It's 3.86, or 5% in the control condition, and it's 8% in the experimental condition. Again, an effect size of 0.47. The number of people with at least 8 weeks of uninterrupted cocaine abstinence, it's 3% in the control condition, it's 18% in the experimental condition. And numbers needed to treat of about 7. Not a huge effect, but a very sizable effect in this kind of population. At least 16 weeks, none in the control condition, and about 6-7% in the experimental condition. Numbers needed to treat 15, not so good. Final 4 weeks of cocaine abstinence, you see a difference, 1% versus 14%. Again, an effect size with the numbers needed to treat of 7 or 8. Oh. Okay. Of course, this is looking at the intention to treat. You can also look at treatment completers. I'll go over that very quickly, because as you can see here, it doesn't make much of a difference. The effect sizes are a little bit bigger in the treatment completers, but that's what you generally want, what you generally see. You want to see it, because if you don't see that, there might be something wrong with your trial. But it's nice that you see it. It's a little bit bigger, not a lot bigger, because so many of our people actually complied with our study. So we also looked a little bit at response and treatment retention. So here you can see the control condition. We had treatment retention of 91%, and in the experimental it's 92-93%. There is a ceiling effect there. So, but you see, numbers needed to treat is much too high. So there is no difference, because there is a ceiling effect. This is more important, treatment response. 47.7% in the control condition, 53.3% in the experimental condition. A very small difference. So also not really significant. But you have to realize, and I'm not going to make much out of it, the funny thing is, when we started the contingency management, which was 2 months after the start of the heroin trial, actually the comparison group, the control group, was actually doing a little bit better at the start of the contingency management than the experimental condition. There was already 44% responders, whereas in the experimental condition it was only 37% responders. So although the difference here is only 5.6%, in terms of the improvement since contingency management, the difference was 12%, which gives a number needed to treat of 8. Again, a very sizable and respectable number. Was there any kind of predictor for the treatment and treatment interaction? There was no interaction effect with the level of cocaine use at baseline. People who used a lot were doing very well, and also people who didn't use a lot. No difference. Treatment history, no difference. Intention to stop cocaine use, that was a difference. This is what we saw in all patients. That's what you saw. This is the average longest duration of cocaine abstinence. You have seen that before. It's 1.8 weeks in the controls and 3.9 weeks in the experimental condition. Now, there were people who didn't have the intention to stop their cocaine. They wanted to participate probably because there was some money to earn. And you see, the intervention was not effective. The ones that actually wanted to reduce or stop their cocaine use, there the effect is very large. So it seems that that is the only interaction effect that we saw. So the conclusion of our trial is the trial was successfully implemented. It's a lot of work. Cocaine contingency management is effective and adds on to the psychosocial intervention to heroin-assisted treatment in terms of reducing of cocaine use. Motivation is a potential effect modifier. There is actually not a lot of effect on total response. So it is an effective additional treatment, and you can save a few more people, but it's not greatly effective. So that's what we have here. It's an effective treatment, but the effect size is small. Heroin-assisted treatment is effective, but 50% don't respond. With this additional intervention, you might add another 10%, but I think we still have to look for, again, alternative or additional interventions. And so what are they? We just started now a trial on prescribing extended release dexamphetamine in these patients. I don't have the data yet, but we just started. That's maybe a way to go for the treatment-resistant patients. Maybe we can improve their cocaine use, reduce the cocaine use by long-acting dexamphetamine in this population. You might also think about another treatment for these very treatment-resistant patients. We just finished treating a not successful patients in heroin-assisted treatment with deep brain stimulation. I can say that the results are quite positive in this one patient. I can talk to you later on it in the corridors more. It's a very invasive treatment, but it might be an option for people who have no effect in all the treatments that we have currently available. It's a challenging way, it's an interesting way, and I think it needs a lot of discussion before we go on with that on a broader scale. I think that was my last slide. Thank you very much for your attention.